evening, everyone. On behalf of IPSAP South State Branch and Child Psychiatry Subcommittee, I would like to warmly welcome you all to today's CME session. We are honored to gather here during Autism Awareness Month, a time dedicated to fostering greater understanding, empathy, and advocacy for individuals on autistic spectrum. Our CME today is particularly important as it addresses a critical and timely topic, empowering psychiatrists, supporting neurodevelopmental disorders in resource-limited settings. Autism spectrum disorder affects millions globally, yet many remain undiagnosed or unsupported due to lack of awareness and resources. Today, we come together to contribute to that knowledge and ultimately to better the lives of individuals with autism and their families. Before we dive into today's session, we are honored to hear a brief message from our President, Dr. GVS Murthy Garu, and our latest newsletter, which contains valuable insights and updates related to our work, will be released. Sir.
Good evening, Nick. Good evening, everyone. And good evening to today's speaker, Dr. Indra Vishal, and today's chairperson, Dr. G.V. Ramanrao Garu. I warmly welcome you all to this CME program, which coincides, as Dr. Mansa already mentioned, with the World Autism Awareness Day. We are honored to have Dr. Vishal, an expert in child and adults in psychiatry from Inlas Hospital, Vijayawada, to share his experiences and thoughts with us today. Thank you, Vishal, for accepting our invitation. And I also thank Dr. G.V. Ramanrao Garu for accepting our invitation to be the chairperson for this CME program. Thank you, sir. And I'm also delighted to release our 5th newsletter of this year. Dr. Ramya, Sri Ramya, please. This is the 5th. Right. Thank you, Sri Ramya. And we need to appreciate Dr. Sri Ramya and her team for periodically bringing very beautiful newsletters, including all our state activities and also upcoming activities. Thank you, Sri Ramya and others. And this is the 5th one we received, and we released today. And another newsletter will be going to release before AP PsychCon. Thank you, Sri Ramya. We need to appreciate your efforts. Thank you very much. And now over to Dr. G.V. Ramanrao Garu for continuation.
Yes, sir. Shall I proceed? Or somebody else is...
Sir, 1 minute, sir. 1 minute, sir.
Thank you, Dr. GVS Murthy for your kind words and your continued leadership. Now, let's proceed with today's presentation. I would like to request Dr. Srividya to read out the CV of chairperson for today's session, Dr. G.V. Raman Rao garu.
Okay, good evening, one and all. Am I audible now?
Yeah, you are audible, Srividya.
Yes,
Thank you. So I'm happy to be part of this webinar because the speaker is my official guru and the chairperson is my non-official, non-formal guru, none other than my father-in-law. So I was very lucky to learn from both of them, and to continue further learning, I'll be sharing the biodata of Dr. G.V. Ramana Rao, the chairperson today. He has done his MBBS from Rangaraya Medical College, Kakinada, and MD Psychiatric from Andhra Medical College, Visakhapatnam. He served as the president for IPS AP chapter in the year 1995-96 and received the Best President IMA AP State Award for the year 2006 to 2007. He is also a recipient of Dr. D.S. Raju Oration Award 2021 to 22. He has been Fellow of Indian Association of Child and Adolescent Mental Health and International Distinguished Fellow of American Psychiatric Association. He is also a member of State Mental Health Authority under the category of Eminent Psychiatrist. He is currently Director and Consultant Psychiatrist at Shanti Hospital, Bhimavaram. He was former Associate Professor of Psychiatry at Ashram Medical College, Eluru. His areas of interest are neuropsychiatry, consultation license psychiatry, and child and adolescent psychiatry, particularly autism spectrum disorders. He has organized several conferences and mental health awareness programs, and his family is full of mental health professionals. His wife is a psychologist. His son, Dr. Subhash, is a psychiatrist, and daughter-in-law, myself, Dr. Srividya, is working as a child psychiatrist. So over to you, Dr. G.V. Ramana Rao.
Yeah, thank you, Srividya, for your nice introduction. Yeah, today's topic is a very good selection by our friend Dr. Vishal. I should congratulate him because this is the need of the hour. Especially the neurodevelopmental disorders are around 15% globally, almost children as well as adolescents together. Almost 1 in 6 people are having the neurodevelopmental disorders. Indian statistics, if you take ADHD, about 15%, and autism spectrum disorders about 1 to 1.5%, and intellectual developmental disorders about 1 to 2% in the general population. And specific learning disorders, very stunningly, it is about 5 to 15% of the school children. If you really take these statistics, it's a huge public health problem, not something related only to the mental health professionals or the medical professionals. And a country like India with a very huge population of more than 140 crores, almost 21 crores of the population, almost equal to the South India's broader population, is suffering from the neurodevelopmental disorders. And it's a huge burden because in a country like India where there are resources, very scarce resources, and naturally it's very difficult to cope up with such a huge burden. So our young psychiatrists are also not getting proper exposure in the child and adolescent psychiatry during their training, except probably in the premier institutions or probably in some of the well-established state mental health centers. In such scenario where the mental health establishments do not have proper manpower, like an occupational therapist or a clinical psychologist or a special educator or a speech therapist, we can't do really the proper work. At this juncture, definitely this topic is very useful. As we know, these disorders start very early in the childhood, and early diagnosis and intervention is a must for all these conditions. By the time they come to the psychiatrist, already the diagnosis, already the disease is delayed, and then only disability appears. The psychiatrist should be able to assess the diagnosis, assess and diagnose the neurodevelopmental disorders with the necessary physical, including the genetic tests, as well as the psychometric tools. After diagnosing the child's condition, we tend to prescribe the psychotropics or the nootropic medication and just not bother about the therapy part. I think here comes the relevance of the today's talk. We should be able to teach the parents some structured programs to engage the child along with some basic skills like self-help skills. We should be able to address the domains of social interaction like how to maintain the eye-to-eye contact, how to maintain the joint attention, and how to improve the social communication, including the language and speech development, and the use of the behavioral therapy for the reduction of the RRPs, restricted repetitive behaviors in a child with autism or some other neurodevelopmental disorder. So psychoeducation to the parents go a long way in reducing the parental anxiety and the stress in the family about the future of the child. We should also have good liaison with the other medical professionals, especially pediatricians and the neurologists, and freelancing with special educators, speech therapists, etc., wherever they are available. We should have a good contact with the non-governmental organizations who are engaged with such activities. So with this brief introduction, I request Dr. Vishal to go ahead with this topic. Thank you very much for giving me this opportunity.
Dr. Vishal Indla completed MD and DND in Psychiatric from NIMHANS in the year 2005, gold medalist and Silver Jubilee Award recipient for being the topper of MD Psychiatry exam held in August 2005 at NIMHANS, Bangalore. Received the prestigious World Psychiatric Association Young Psychiatry Fellowship Award for the year 2007 at Melbourne, Australia. Received the Eminent DNB Teachers Award from ANBAI in Hyderabad 2019 at Hyderabad. Received 12 Teachers Young Achievers Club Recognition Award in the year 2013. Gave a TED Talk in 2017 on topic At Work, Less is More. Instrumental in starting the DNB course in psychiatry, affiliated to the National Board of Examinations, and postdoctoral fellowship in child psychiatry, affiliated to NTR Health University, Andhra Pradesh. Currently Chief Psychiatrist at Inglas Hospital, Vijayawada. Director of ICGC, Chain of Child Guidance Clinics in Vijayawada, Hyderabad, Vizag, and Mumbai. Director of Inglas Shantiban, a 120-bedded hospital, rehabilitation and de-addiction center in Vijayawada. Co-founder of a virtual reality platform for common mental health disorders called Avika. Elected as South Zone Representative to National Council of IPS 2021-24. President-elect IPS AP State Chapter 2016-17. Authored many research articles and wrote a book on parenting titled Good Parents, Good Children in Telugu in the year 2007. Faculty in many national and international conferences. I would like to request Dr. Vishal Indla to start his presentation.
Is my voice audible and the screen visible?
Yes, sir.
Yeah, thank you, Dr. Raman Rao Garu, for your kind introduction to the topic. I rate Dr. Raman Rao Garu's knowledge in this field as extremely deep. So it's an honor presenting with him chairing this session. And thank you, Manasa, for your kind introduction. So this presentation will be divided into two parts. The first part will be on the diagnosis, how a psychiatrist can make a diagnosis quickly in a busy OPD. And the second part would be on some of the home-based programs that we can give to our patients, the child's caregivers, who can then do those things at home without much difficulty, especially for some of the core deficits that one notices in autism spectrum disorder. Though the title is neurodevelopmental disorders, I'd like to restrict myself to autism spectrum disorder because that is the prototype and what a psychiatrist can do in a very busy OPD. So as you all know, autism spectrum disorder is a neurodevelopmental disorder characterized in varying degrees by difficulties in social interaction, verbal, non-verbal communication, and repetitive behaviors. I'll give you two cases just for a flavor of what generally happens when we see these kind of children who have these problems along with their parents or grandparents. So this is the case of a 4-year-old child who was referred by a pediatrician. The child was not saying any meaningful words, was not making eye contact. He was not responding to his name call. After thorough evaluation, it was conveyed to the parents that the child shows symptoms of ASD and that he should be starting therapies at the earliest. Then the parents immediately started arguing and blaming each other. The grandmother who was there kept repeating that the child's father also spoke quite late, and all this evaluation was absolutely unnecessary. This is one case. Another child, 3-year-old, a boy presenting with symptoms again of autism. Parents both were doctors, and when the diagnosis was conveyed, they were in denial initially and did not take it positively. In fact, they were asking the doctor to check if he actually meets all criteria and actually has autism, or if it is just some virtual autism or something like that. Initially, they were hesitant to undergo therapy, but the child does not need therapy is what the parents initially said. But after a lot of explanation, psychoeducation, they finally agreed and started therapies. And when the child starts early on therapies, usually the child shows a lot of improvement, like what happened with this kid. Some of the emotions experienced by parents while breaking the diagnosis, well, denial, shame, very hard emotions to break through and move forward with therapy. A lot of time goes in actually talking to the families about some of these things like guilt, self-blame, confusion, helplessness, etc. Factors to consider when breaking the diagnosis. First and most important is to explain the basics of autism and the need for intervention, because many times parents come with their own idea of what autism is. There is a lot of misinformation online, and parents usually reach out to Google and get their information firsthand. Most of the time, some of the things, especially in terms of what causes autism, is not correct in the public domain, and some of their beliefs and about autism are totally misplaced. So making parents understand that it's a lifelong neurodevelopmental condition, it won't go away after a few years. There is no quick fix or a medication or an injection which can take care of these things. And it is not caused by bad parenting, vaccines, or even the lockdown, because a lot of them think, they blame the parents, the mother blames the father, or the grandparents, the in-laws blame the mother, etc. That happens quite often. Vaccines are blamed, but at this time we do not have evidence that any of these things actually lead to the core features of autism. Many of us think that the challenges with autism and other NDDs are only during childhood, but it is very important keep in mind that these challenges are also more pronounced during adolescence and even during their adulthood. So let's also just briefly look at what could be the main challenges in different age frames. Of course, in childhood, you all know they have difficulty dealing with their changes in routine. They have huge sensory issues. That is something that is very specific to childhood neurodevelopmental disorders. It could be stimming, it could be sudden aggression, it could be catastrophic reactions, things like that, which are very specific to childhood. Then coming to adolescence, usually difficulty in communication, both body language, gestures, spoken language, dealing with hormonal changes, maintaining and forming peer relationships. These are some of the challenges during adolescence. In adulthood, of course, it's more about marital relationships, romantic relationships, finding employment. It's a huge challenge, and many times parents have a lot of difficulty getting them into proper relationships, and many parents have this concern that what next, what after us, and that is some thing that they want to answer through marriage. And many times marriages are difficult because there is an issue for these kids who grow up into adults, especially with marital romantic relationships. Finding employment is a major concern, social interactions, money management, and of course, there could also be a host of co-occurring mental health conditions, not only in child adolescent population, but even in adults with autism. So at our clinics, generally after a detailed history by the psychiatrist, we definitely ask whoever is the referral mode. If there is a teacher involved, if there is a pediatrician involved, we try to get in touch with them and find out what their concerns are, especially to know what is the symptom that they notice first. Because many times, parents are either downplaying or focusing on certain other symptoms which may not be of significance to us. So it's always important to also talk to a referral person, could be a teacher or a pediatrician. And once that is done, if you have the benefit, we do a clinical psychological evaluation, basically getting their IQ done. Depending on the age, there are various assessments that can be done. We also assess the severity of autism. We use scales like ESA, etc. Then, of course, we have the luxury of having an occupational therapist, a special educator, speech therapist, which with the help of the reports of all these people, we make a final diagnosis. You might wonder why, when you have a clinical diagnosis, why do you want all these things? Well, because these things not only help in diagnosis, but also when they start therapy, it also helps them to establish a baseline from which they can titrate what kind of therapy benefits most for a child. And occupational therapist will do his or her work about how are the gross motor, fine motor skills, etc., etc. Speech therapists would look at the speech language communication part. They do that evaluation. So all these things will give us a more comprehensive picture about the child's situation, so that the treatment can be multimodal and can be fine-tuned. So what if we don't have a multidisciplinary team, which is the case for most of us? Some of the basic questions that you ask the parents in a busy OPD, let's look at those questions and what kind of observations. So what are the questions? What are the observations? When you look at the questions, some of the things that you want to know are, well, does the child look when you or someone calls out his name? It's called name call. Does he respond to his name? That's a very important indicator. Does he point to common objects or persons when asked to? Does he follow instructions like, look here, bring this? When he's absorbed in something and you try to show him something else, for example, he's playing with a small car toy and you want to direct his attention towards, say, the moon or, the fan, does he immediately distract himself and look at what you want to point to him? How are the milestones? Is there something that he picked up and now does not do anymore? Basically meaning, many times they gain certain milestones age appropriately and then start losing them. So also important to understand if something like that is happening. Reciprocal social interaction. Does the child respond to peekaboo? Also gaze monitoring. Oh, baby, look, there is a toy. So again, is the child able to distract himself from what he's preoccupied with and look at what the mother is showing to him? Proto-declarative pointing is when does the child use his index finger to point to something that's interesting? See, normal kids, when there is something interesting that they notice, they also want somebody else to notice. Human beings are social animals, and a child is no different. So they want their mother also to look at that interesting thing and have the same kind of joy. And this is again absent in those children who have autism, core autism features. Communication, you would observe their verbal, non-verbal communication, eye contact, facial expressions, gestures, imitation, imagination. How do they use their toys? Are there any problem behaviors? What are they preoccupied with? And most importantly, any unusual sensory interests or aversions. It could be with food, it could be with a soap, it could be with a powder, a perfume, a smell. So in summary, I would think if somebody wants to practice looking at children with the autism spectrum disorders in their clinic, it's always nice to have some space. Most of our adult setups are kind of cramped, but luckily for us in our child clinics, we generally make sure that they're very spacious and the doctor's room and all the therapist rooms are filled with toys. So it's very easy. You just let the child play. You observe what toy he picks up, how he plays with them, observe the reaction when he's separated from parents. Check for imitation, joint attention, response to name call, observe for any toe walking or W sitting. W sitting, you can look at an image, you will immediately know. It's a peculiar way of sitting. Observing eye contact, response to commands, observing for sensory symptoms, repetitive behaviors, trying to strike a conversation as a clinician and see how it goes. Echolalia and pronoun reversals. Pronoun reversals also is very common in these kids. So if, say, the child's name is Arnav and he says, if Arnav wants a chocolate, instead of saying, I want a chocolate, he'll say, Arnav wants a chocolate. So that's what happens with these kids. That's pronoun reversal for you. That's quite common in these kids who have these language communication deficits as well. So these are some easy ways to pick up a diagnosis. I personally think it's not at all difficult, especially if you give them a few minutes of time and a lot of space, some toys in your chamber. I think if you let them play for 10-15 minutes, the diagnosis generally is quite striking. Of course, in mild cases, you might find it a little more difficult and challenging, and then you might want more information from other therapists or from parents and referral sources. Investigations, well, not a big fan of all the investigations. This is just for your understanding, but some things that we definitely do are hearing and vision evaluation, because those are some things that we want to make sure we have filtered off before we start our treatment interventions. Management, as I mentioned, will be multidisciplinary team, medical management, biomedical interventions, therapies. We'll just focus on what a psychiatrist can do. So let's look at the psychopharmacological options. Well, most of the pharmacological options do not affect the core features of autism. In fact, there is no drug as on today which can focus or target the core symptoms of autism. Excuse me. The target symptoms that we can actually help with are irritability, hyperactivity, inattention, impulsivity, repetitive stereotypic behaviors to some extent, sleep disturbances. The drugs that have been approved by FDA are, of course, risperidone and aripiprazole. I've given a wide range of doses which are approved by FDA, but of course, you will have to individually titrate. And you all know the adage in these kind of general populations, you want to start low and go slow. And there is no hurry to build up doses very quickly or use very high doses, because you should remember that these children are generally more prone to the side effects of any of these drugs. So we use risperidone, aripiprazole quite often. We also use a lot of clonidine for especially severe aggression, inattention, impulsivity. Methylphenidate is an option, but I'm careful about using it because it's not going to be the same response for all the children with these symptoms. We also use SSRIs, especially when there is a lot of compulsive behavior, repetitive behavior, a lot of rigidity in their attitude and behaviors. Second generation antipsychotics, some of the others can also be used depending on any other symptoms that are present. For example, somebody who does not eat much, you probably want to try olanzapine instead of risperidone, though it's not an FDA approved drug. It's still something that one could try. Valproate also, especially if there is comorbid epilepsy. Melatonin, a very useful drug, especially when the child is very young. He has significant problems, behavioral problems, sleep issues. Melatonin is not at all a bad option. Using low doses of melatonin to help with the biological circadian rhythms of the child actually sometimes does wonders to the overall behavior. If not improve the core symptoms of autism, definitely it improves some aspects of the behavior once the child starts sleeping better. So we do all these things at our clinics: occupational, speech, behavior, group therapy, remedial, special education. Role of therapies: quickly, OT focuses on the goals and developmental milestones that improve their daily functionality. Say it could be buttoning their clothes, going to the toilet, cleaning themselves up. Those are the kind of things that the OT focuses on. It also focuses on how the child moves, plays, communicates, and most importantly, with some of the sensory behaviors that are quite disturbing for the parents and also overwhelming for the child. The stimming behaviors, etc., they respond to occupational therapy quite a bit. We also do a lot of group therapy, which focus on connecting the kids with like-minded peers, provide a supportive environment where kids can share their skills, offer encouragement, work together to develop new skills, practice social skills in a safe and structured setting. So group therapy also helps. Many families have this myth that, if you have a few kids with autism, the child would learn the bad things from each other. Well, when it is done under supervised settings, it actually gives very good results, and we have demonstrated time and again in our clinics. Speech therapy, of course, focuses on speech, language development, and communication. Remedial therapy. So many parents are also interested that if especially the child has mild autism, they want their children to go back to normal schools. And to the extent possible, we also encourage that a child should be able to attend normal school with peers who rather than asking them to go to special schools and things like that. So for that, one of the basic things would be remedial therapy, which focuses on pre-reading, pre-writing, fine motor skills, attention, focus, and cognition, because these are some of the most important skills if a child has to attend normal school. Some of the basics of therapies and milestones one must be aware of. I'm not going to the details of the milestones. You will get this anywhere. But the whole idea is, when you want to start any intervention for a child with these kind of symptoms, it's important to know what their baseline is. And if for that, you will also have to know what normal milestones are. So it's important to know what the normal gross motor developmental milestones are, what fine motor skill milestones are, similarly social emotional milestones, and also academic milestones. This is something that generally we are not taught in our curriculum, but when I interact with our therapists, this is something that also is constantly checked for in these children. So basically, these are pre-writing line development skills in children. Usually, it's the vertical line that a child initially is able to draw, followed by a horizontal line. If you look at this slide closely, you can see that at 2 years of age, roughly, a normal child attempts to draw a vertical line. And generally by 3 years, most kids master it. And so we have given age for all of these things, general developmental milestones for pre-writing skills. But if it is further delayed, then of course you can work selectively on those things. Again, these are some of the speech milestones. I've just highlighted the important ones. Babbling is something that happens around 4 to 6 months. That's one thing that one can benchmark. Again, around 1 year, the child should be able to speak comfortably 1 or 2 words. If that's not happening, there is speech delay and one needs to be wary about that. 2 to 2.5 years, usually 2-word phrases. 3 to 3.5 years, usually 3-word phrases. These are rough milestones for most normal kids. So that gives you a template on how much a particular child is lagging. So what are our goals? Our goals would be to promote eye contact, improve response to name call. These are things Dr. Raman Rao garu mentioned initially. Ultimately, a parent wants these things. They want the child to improve following commands, improve sitting tolerance, attention. I know parents who keep telling me if they have to go to a function, a marriage or a party with a child who has autism, most of the times they have comorbid hyperactivity as well. And the mother is constantly on the run behind the child. It becomes very, very overwhelming and exhausting for a mother to take a child outside, or for that matter, even any parent. And many times the best way to handle this would be to avoid these kind of social occasions. That's what most parents do. So improving their sitting tolerance, attention, improving their gross motor, fine motor skills, and enhancing play and social skills. Well, these are essentially in a nutshell what will take care of most of the other concerns any parent with neurodevelopmental disorders has. Quick note on effect of screen time on kids. Well, this is applicable to all the kids, but more so for kids with neurodevelopmental disorders. There can be some positive effects, but the negative effects are much, much more severe. The positive effects are only when it is to a certain limited time and under proper supervision by a parent. There are a lot of negative effects of this, which I've just marked there, but won't go into the details. Most of these things. I'm sure every day we see a lot of kids and adolescents with these kind of problems. Also want to highlight this because a lot of parents ask us, and whenever we go outside to talk about these conditions, most popular question, favorite question for most people is, what are the screen timing guidelines in India? Well, IAP has given those guidelines, which are basically replicas of what has been suggested by the Western agencies. Below 2 years, there is absolutely no screen time that's permitted. Unfortunately, I'm sure you all know how even a child who is 6 months, 9 months is given indefinite screen time, right from getting them to the potty to making them eat. Gone are those days when a mother takes the child outside, points towards the moon or points towards the stars and feeds the child. Now, most of the times these things happen with their favorite rhymes on one of the apps, usually YouTube. But the maximum screen time of 0 for below 2 years, 1 hour supervised for 2 to 5 years, and less than 2 hours for 10 years and below. So basically, this 2 hours is like a benchmark for most of us. I mean, including teens and adults also. Of course, not for your work, but for recreation and for other purposes, for entertainment purposes, 2 hours is the adequate time. Anything more than that and above 3 hours is the tipping point for most mental health issues. Screen time should not replace other activities such as outdoor physical activities like sleep, family, peer interaction, and also monitor the content being watched. Make sure that it's educational, age appropriate, and non-violent. Nowadays, when routinely we ask the kids when they come for evaluation, for not only for autism but even in other conditions, when we ask them what games do you play at home, previously, whatever they say, I would be able to understand. But nowadays, some of the games that they talk about, I really can't understand because most of them are online games. There's hardly any mention of outdoor games that children today play. So that's something that is more pronounced and can have more detrimental effects in neurodevelopmental disorder children. Simple activities that could be done at home. Well, I have a few videos here and also a few pictures here. So I'm hoping that the audio would be clear for you so you can get the message across. And the next few slides would focus on some of these things on, what could be some simple activities that you could get done in your clinic with the help of a therapist, or you could also give them as home-based activities for the families to follow up on. So let's start with some of the pre-writing skills. Here you would just draw big dots like this and ask the child to join them. And then there are something called as pegboards. These are available everywhere on Amazon, everywhere else. These are basically for sequencing, for color identification, for concentration. And sequencing is a very important pre-writing skill. So I'll play this small video. It is then you will understand by yourselves. Please confirm to me if the audio is...
Are you? Your Leher? Here, baby, here. Put it here. Come on, Leher, you can do it. Uh-oh.
Was the audio there for this video?
Yes, sir.
Yeah,
Yes,
it
sir.
is there. Audio
Yes,
is
sir.
there.
Okay, so this, by the way, let me also thank our Bombay team. Mumbai ICGC team has supplied, given me these videos, which are for educational purposes, and they have been taken with the consent of the parents involved. So the other thing that one can do is to engage with sticking of common day-to-day food items like dals, lentils. You see this? This is a sheet. The mother or somebody draws a picture here and then makes a small design and asks the child to stick dal or lentil on this. Again, this is a very good skill that would focus on attention, concentration, eye-hand coordination, fine motor skills, and also can be one of the important prerequisites to pre-writing. Okay. Again, here these are very, very simple things, pretty easy to do at anybody's home. You take a black board or a black sheet, which could be pasted on a wall at your home. Let the child explore with different colored chalks and gradually begin with connecting the dots. So let me again show you a video to, make this more easy for you to understand. Basically, you put the dots and ask the child to connect those dots, and those dots could be used to make patterns or to draw alphabets. So a whiteboard also like this here in this picture can work both as a board and table. You ask the child to connect the dots. So these are all simple activities. Look at the child connecting the dots. Now you could make the child
Good
draw
job.
patterns or alphabets like that.
Sleeping line? Another sleeping line. Good job.
So that's how alphabets, the kids, normal kids learn it much easily, but it's not easy with these children. A remedial trainer can help the child learn these pre-writing skills and then alphabets so that they can build words based on that. Once basic pre-writing skills have developed, copying should be the area of focus. Now, if you look at this, there is a small book which has certain things, certain numbers, etc. Again, these I'm sure you've all seen. These are very easily available. They're not expensive at all. So you would just ask the child to copy a particular design. So place a book from which the child could copy simple items like numbers, alphabets, etc. Let's look at the video. So the child looked at this design 6 years and then he just tried to copy it. Obviously, this has to be done only after he develops the basic pre-writing skills which were discussed in the earlier slide. This is for some basic arithmetic because again, this is an important life skill for everyone. So there are multiple ways to teach them arithmetic. This is one thing. You create a cutout like this for simple addition and subtraction. You all know how we were taught arithmetic in childhood. We use our own hands and fingers, but a child with special needs, developmental disorders, they could be given something like this, which they can use much easily to develop this concept. Again, this is something that helps concept building and arithmetic. So there is one ducky here, there are two here, there are three here, and there are numbers depicting that. So they have a 3D feel of what exactly one is, what exactly two is, how many is three, etc. And then, of course, you also have self-made sheets like this for simple addition and subtraction. So basically, you draw a picture like this, you put a few colored beads on this side, a few colored beads on this side, and then make them just count, saying, okay, this is totally 5, these are 2. Then you use any of these methods to help them count these things. These are a little more advanced skills and they take a lot of time. It's not easy at all, especially some of the arithmetic skills. But I thought it is important that you get an overall perspective of what all things can be done. But we know parents, some of them who are extremely committed and who spend a lot of time doing these home-based assignments as well. Get creative with ice cream sticks. Ask the child to copy a pattern or an alphabet. Concept building is benefited by this. Focus problem solving can also be benefited. So these are very easy things again that can be done by anybody at home. Some play-based activities. Now this one, many times these kids have sensory overwhelm. They could be flapping, they could be rocking, they could get extremely vocal and hum. These are all stimming behaviors. When somebody is very overwhelmed like this, one of the things that you could do is to actually put them in a darker place. We have these kind of rooms in our clinics, but at home, obviously you can't create a room separately for this, but at least you could create a dark place like that, make the child be in a soft blanket, place a small light inside and swing the child while holding from both the ends. This gives sensory stimulation, calms and relaxes the child. Let me see if I can play this video. So that's a video that helps the child to calm down immediately from his sensory overwhelm. When you put them in a calm, dark, cool environment with a caretaker like a mother or a therapist, just petting them and keeping them there for some time with some lights. Messy play, again, very helpful. Something most children enjoy. Let them explore with paint, sand, shaving foam, etc. Again, most of these things are very easily available. Paints, again, a little difficult, complicated, but sand, shaving foam are quite easy and they are absolutely harmless. These encourage self-confidence, independence, and creativity. Again, these are Lego blocks available quite commonly anywhere. Let the child get innovative and create whatever design he likes. Helps in building creativity, flexible thinking, etc. And these are also blocks which can be used to create from cardboard and bottle caps. These help again in building concentration and concepts. Again, some basic toys which are available anywhere in any market. Let the child explore with various toys. It's important that a caregiver also is present while the child is playing, because we don't want the child to get preoccupied with one aspect of the toy only. So let the child play in any manner, but it's always good to have some supervision there. Encouraging the child to build self-confidence and creativity. Sitting activities like this also are quite helpful when they are able to put these designs on the blocks. Helps with, again, a lot of skills which we discussed earlier. These are hula hoops. These are again available in the market, but if you have the kind of space, then you could arrange these big circular hoops in this manner, and then they can play this hopscotch. So basically they hop from one to the other, or you could give them a pattern. You go from the pink to the green only, sometimes pink to the yellow one, and they have to follow instructions exactly. Again, all these things help gross motor skills, thinking, concentration, cognition generally. You can also place chairs like this, small chairs like this, and at home if possible. So these are things that are usually available at home. This is in a therapy setting, but these are things any home would have. And then create a sequence and make the child walk over it. It builds focus, gross motor skills, coordination. By the way, it also can be done with mats and pillows if you still don't have these kind of things at home. Again, small clips and small stones, pebbles. Ask the child to pick up the pebbles with the clips. Helps with concentration, fine motor skills, coordination. Kids initially might not enjoy these activities, but once you are there and reinforce things for them positively when they complete a task, it becomes much easier and enjoyable for the kids. Now, these are activities that we engage the parents and the children together in our therapy settings and then ask them to do these things at home by themselves. Like, for example, throwing small balls or items in a bucket. So the child here would throw these things into that. It helps build concentration. In fact, if there are two SIBs, one normal child and one with a developmental disorder, you could even engage the elder kid or the one who is healthier to do this with the other child. One of the books that, most of these kids, by the way, are kids with neurodevelopmental disorders. It's not easy for them to read books, but there are certain books which are specifically made for them. Those are textured books. So basically, when the child feels it, he can feel a texture, which is generally very soothing. I would recommend one such book. There are many like that, but the book that we generally advise parents is The Very Hungry Caterpillar. It has very nice textures in all the pages, generally very soothing for the kids with developmental disorders, especially when they do this subsequent to one of the activities that you want them to do, and give it as a reward for them to read a few pages and feel those textures. These are beading activities, very self-explanatory, available again very easily in the market. They help with some of these things, focus, fine motor skills, simple puzzles, just for them to put the designs in proper places, helps concentration in problem solving. Small jigsaw puzzles, nothing very complicated. Let the child get creative with clay and Play-Doh. This is quite helpful. So, and it's very easily available as well. Colored clay is also available now quite easily. So these are some things that can be done. Exploring with dough and atta, if nothing else is there. Your chapati pindi and things like that could be used if Play-Doh or clay is unavailable. Simple vegetables at home that are there can also be used for these children to explore them, their textures. It develops a sense of independence. It also builds a kind of family spirit when the parents and children do it together, especially if the sibling is involved. Give the child a color code to create something like this with Lego blocks. Again, it's an advanced skill, but you could always titrate it based on the child's situation. Very easy activity here again, helping with coordination and gross motor skills and also attention span. You have a glass with water, you have a sequence of that, and the child just blows the ball from one glass to the other. These are diyas, very easily available. You just ask the child to decorate a diya. There is no particular design. Any design is good enough. But the important thing is that the child starts creating patterns, starts making him to think, helps his cognition and attention span. If you have tiles like this, you could draw circles with a chalk and make the child jump. You could get more creative by writing numbers and instructing the child to jump into a specific number that is called out. So for example, you write 3 and 6 and you ask and 7 and you ask the child to jump from 6 to 3 or 6 to 7. So it builds multiple concepts when you do these kind of things, and you can get as creative as you can. Just make sure the child is safe in the environment. Otherwise, you can use your creativity. These are just some templates of activities that we generally advise our families who come to us for help. And this is something like, pouring from a bowl or a big vessel into an ice tray helps build concentration, coordination. Now this, I'm sure every household has something like this. Again, activities with gym ball. This is from our therapy setting, but the same gym ball can be available everywhere and can be used for bouncing activities. Bouncing activities surprisingly have very good impact on their gross motor, fine motor, especially stimming behaviors also. Now, I don't know the exact theory, but our occupational therapists do a wonderful job with this gym ball and multiple activities. I'm going to show you one or two of them in the next couple of slides. This is just arranging blocks. Again, the parent draws a design and just asks the child to put these things across. So the next couple of slides are videos. I think in another 5 minutes, I will end my presentation. This is a child with hyperactivity. This is our therapist at Bombay working on the child. Again, the same thing can be done at home. So kids with hyperactivity, what the therapist is doing with the child. Let's look at this. This is something that is somehow hugely helpful for these children who have a lot of these sensory issues. And these are not very complex activities. Anybody can do it at their own home with a supervision of a family member. Now, this is another thing which is extremely useful. This is basically for eye contact done by one of our senior therapists at Bombay. Please have a look at this. Eye contact is a major challenge, by the way, for a lot of these kids. So let me see if I can play this.
Few tips which you can use to initiate eye contact with your kids. Whenever you take your child to a garden and make them sit on the swing or slide, you could stand in front of them while swinging and stop the swing suddenly so that they would look at you. Similarly, you can do while they slide down. Play Play peekaboo and blow bubbles. You could make funny sounds to gain their attention. Let them pop all the bubbles, wait until they look at you, and then blow again. If your child responds to his or her name, call out their name and then blow the bubbles. Introduce any board game, sit in front of the kid, call out their name and give a piece at the child's eye level. Give rewards like a high five or very good when they make eye contact. During motor tasks or obstacle course activities, you could stoop down to the child's level and give them a command and then pause for them to reciprocate or reply. Kids enjoy rhymes, so you could recite it as they look at you. You could also do this in front of a mirror and let them copy you. Face painting creates natural proximity or closeness, and both child and you would be looking at each other's faces. And most importantly, screen time, that is watching videos, etc., should be kept to a minimum. Do not always say look at me or look into my eyes. Let it occur naturally, and eventually it will with all these tips.
That's a very useful video on maintaining eye contact because most parents have huge difficulties getting this done. This is again a summary of some of the skills. I will skip this. Okay, this is about speech, video for imitation and speech to encourage babbling. Let's see if I can play this video.
Tukar. Ting, 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 ting.
So the therapist is trying to show the image of a bell and makes the sound of a bell and then asks the child to imitate that sound. Again, here the therapist shows a book which has which has 3 pictures in sequence. You will observe what happens next.
Small boy is flying small kite. Boy is flying medium kite. Boy is flying large kite.
That's how, you know, the images are shown and the kid is made to look at the image and then connect the words and slowly develop language. I've skipped some of the videos for lack of time. I thought we should have a few minutes time for interaction. Finally, before I end, I'd also like to say that now there is more and more evidence that, you know, sunlight, nature also have a positive role to play in children with neurodevelopmental disorders. It could both be helpful for normalizing their circadian rhythms and also can be very helpful for some of their gross motor, fine motor skills as well. So make sure that these kids are also given liberal amounts of time in nature. It could be pets, it could be with mud, clay, things like that, gardening, etc. So whatever is possible for a parent, they should be able to do those outdoor activities, and that also makes sure that the screen time automatically gets reduced to a large extent, which also would add to the benefits for this child. So we must teach our children to smell the earth, to taste the rain, to touch the wind, to see the things grow, to see the sunrise and nightfall, to care. Basically, nature plays an important role. I always wonder, of course, this is not proven by any research, but I always wonder if one of the reasons why the prevalence figures for autism are skyrocketing. Every year the data comes, you are looking at the prevalence figures going up and above. And one of the things we do not know for sure, but one of the hypotheses is that nowadays kids are not getting enough sunlight and nature, but are not exposed to these things, are actually exposed to more and more gadgets, digital world, indoor activities, etc. Of course, this is not a proven fact, but I always wonder about this. I finally conclude by thanking the IPS-AP State Branch for organizing this webinar on this important occasion. It's a very dry subject, a very dry topic. Not many psychiatrists are very keen on knowing more about some of these things, but I think our state branch wanted to make sure that we have some learning on this. So I congratulate them for having this webinar, and I thank them for giving me this opportunity. I now hand over to our esteemed chairperson, Raman Rao garu. Thank you.
Thank you, Vishal, for your wonderful presentation, because you have almost made everything look so simple so that everybody can practice at home, but it's not the truth. Because to diagnose itself is very difficult, And we see lots of our colleagues or even the pediatricians, how they miss these children with autism spectrum disorders being missed and all that. So the assessment itself is very difficult. And also the therapy part is the most crucial part, because most of the times our colleagues, whenever they diagnose a case of ASD, they try to just prescribe some psychotropic medication, and the child is still not improving. They keep on increasing the doses. Definitely, that is not the right way to do, because they may develop the tardive dyskinesia and other things in the future. So the least medication in the youngest age groups, and the best thing is the therapy. So how to teach the parents? We have listened to Dr. Niman's Professor John a couple of days ago, parent-mediated therapies, and now Vishal has very clearly demonstrated through videos and then the photos, various therapies, maybe occupational therapy, speech therapy, and then remedial therapy, so on and so forth. So wonderful presentation. Really appreciate you for bringing such a wonderful presentation. To all our colleagues on World Autism Day, I thank you very much. And now this is open to discussion, and I ask Dr. Manasa to go ahead the questions that is there in the chat box, or others can also, Dr. Srividya, Dr. Manasa Ram, they're also there, they can also coordinate.
Thank you, Dr. Vishal, for a wonderful and insightful presentation. I would like to read out certain questions from the chat box. Sir, kindly guide us as to what to do, as ASD and IDD with or without seizure disorder is quite common in rural district. And your take on the role of sulforaphane in ASD.
I have absolutely no experience with sulforaphane, so I'm not the right person to comment on that. If anybody else has experience with that, they could give the answer to this. But I'd like to say, if somebody has ASD and IDD, which is quite common, well, we would move with any of the frontline anti-epileptics depending on the child's age and weight. There are multiple options, so we would go with any of the frontline drugs. Now, of course, if there are severe behavioral issues as well, I would prefer the drugs that we already discussed, like low-dose risperidone and aripiprazole.
Is there any role for cannabidiol drops and gut microbia in ASD?
So again, there is no evidence enough to suggest these things now. However, especially cannabidiol, there is no evidence to suggest that they would be beneficial. There are anecdotal reports by certain caregivers, but we can't go by that. However, gut microbiota, probiotics, definitely, again, the evidence base is not huge, but we have been using probiotics, natural form like, yogurt, etc., or it could be some of the currently available probiotics in the market. Both of them have been helpful for certain children, but it is not like a blanket that you have to give probiotic and all kids respond in the same way to probiotics, because some of the kids, even with probiotics, develop severe diarrhea and GI symptoms. So one needs to be careful in using probiotics, but definitely some role for probiotics. Definitely not going to consider cannabidiol drops at this stage.
So Vishal, I have one observation. In fact, we had a discussion in the APA when you also came there in 2023. Then one psychiatrist, he was talking about the autism and the role of cannabidiol in the tantrum behaviors, especially severe tantrums. There is a definite role for the cannabidiol. That's what he argues. In fact, I just asked a question to him: can it, aggravate the psychosis as the child grows up? He said, no, absolutely no. So I think there is some evidence to say that cannabidiol is going to be very useful for severe tantrum behaviors in some children, especially very severe autistic children.
Sure, sir. In fact, in severe epilepsy, which is a comorbid condition for autism, it is already FDA approved. But when it comes to just core autism, again, I'm personally of the opinion that at this time we don't have the weight of evidence to think of those things as a treatment option, at least in our country.
Role of L-carnosine in autism.
Again, very controversial. Recently, I was in the Bombay Psychiatric Society meeting. I was speaking alongside one of the senior speakers, Dr. Alka Subramaniam. She's a very well-known figure in child psychiatry. And I'm just quoting her. She's very clear that these things have absolutely no role because there's no evidence. But I have a different take. We have been using L-carnosine quite often in children with developmental disorders, and there are certain kids who have definitely shown some changes in their social communication, cognition aspects. Not only L-carnosine for that matter, omega fatty acids, L-carnosine. Certain times, if the child diet pattern is very bad, maybe even adding certain vitamin supplements. Of course, you don't want to bombard the children with multiple drugs. That's not the intention at all. But certain times supplements do play a role. And we are very clear in one thing, that there is no drug that can treat the core symptoms of autism. We are going to tell it very straight to the parents and the family members. But all we are saying is these are all small, connecting the dots kind of a thing to help the child function better in his day-to-day life. So in that sense, yes, I would consider L-carnosine, omega fatty acids, those kind of drugs for kids with developmental disorders. But there is no evidence base yet.
I would like to second it, because in our regular OPD practice, even we do come across many children who are yet to start their therapy, but they show certain improvements after starting L-carnosine. Sir, how early can we start children on melatonin dosage and how long?
Good question. So melatonin, again, there is no particular guideline, but as early as say around 3 years to 4 years, I think is the earliest that we have started very, very low dose of melatonin. So say around, you start with the lowest possible dose, maybe around 1 milligram, 2 milligrams, and then you see how it goes. There is no particular formula for this. And usually we tell the parents that we don't want to give any medication at this stage, but sometimes we come across parents who are so distressed and exhausted because the whole night the child is not able to sleep, and the whole night the child is cranky, stimming, shouting, humming. It becomes impossible for the parents or the child to have a decent sleep and have a better day the next day. So in those kind of situations only we think of medicines at an early age. And melatonin, we have started, the earliest is around 3 years or so, but we clearly tell and document in the file also that this has been discussed threadbare with the family members as to why we are starting it, and that they've been informed about the reasons and things like that.
Dr. Bharati Garu is asking one question. She is appreciating you for a great job, and heartening to know there is so much that can be done to improve an autistic child, and requires tremendous patience, time and energy and money in the parents. Do you think even the low doses of antipsychotics at such an younger age is really necessary?
Definitely not necessary for core symptoms of autism. We look at giving antipsychotics only when there is severe aggression, severe stereotyped behavior. Those kind of things definitely warrant medication. That's why they are in the first place, FDA approved. Otherwise, they wouldn't be there. But as Dr. Bharati Garu pointed out, medication is not the first line of management for autism spectrum disorder. It has to be a lot of education to the parents to accept the diagnosis and involve and engage meaningfully in multimodal therapy. When therapy is not available, they should be able to do some of the home-based activities that we have just discussed here. Some of them are easier ones, some of them require a lot of patience and time, but medication does have a role, but definitely not the first line management in ASD, or for that matter in any child adolescent condition.
Vishal, do you think SSRIs are really safe in some of these autistic adolescents with mild depression, because already they have aggression and then violent behaviors, but just because the child is showing some amount of depression, do we venture to start these antidepressants, SSRIs? Because today itself I received an SMS from one of my old patients who shifted to US, and there the psychiatrist has prescribed sertraline. And this man is the son of a doctor's couple, and he Googled and said that the SSRIs are having suicidal tendencies and then vulnerability for violence. Can we really use them? He asked my opinion. What is your opinion?
So not only in children with neurodevelopmental disorders, for any child adolescent, using SSRIs comes with a huge risk. The major problem with SSRIs is suicidal thoughts and all that for me are secondary concerns. But many times when they present in that age, whether it is unipolar depression or actually a bipolar disorder being presented as an episode of depression, that will be my major challenge. And I will never know that when I see them in the first episode. A child with autism with depression or a normal child adolescent, a teen with depression, I would have the same concern with SSRIs. Again, if their depression is mild, I would still look at using therapy liberally for the child to help them with these things. But if I'm forced to use a drug, then of course I will make sure that there is no family history of bipolar, and I will do all my routine checks that we have to do to make sure that this is actually a unipolar kind of a depressive episode. And if I'm very, very certain, only then as a not the first resort, but definitely I would consider SSRIs, but definitely I would be very, very careful prescribing SSRIs for any teen.
In such a case, what is your option? Suppose SSRIs, the parents are afraid to take the SSRIs. So, but still the child is having depression and maybe mild depression, but the past history of violent outbursts and leaving the home, things like that. So, what is the second option in such a case?
Sir, if the depression is, we are very clear about the core vegetative symptoms of depression. Fluoxetine has huge evidence base, huge evidence base. Though it's an SSRI, all SSRIs cannot be taken with the same kind of flavor. Fluoxetine has huge weight of evidence for it, even in special populations like kids with neurodevelopmental disorders and even with normal child adolescent population. So I'm saying that it's not that we should never use SSRIs, but you should be a little more careful ruling out some of the other conditions. However,
what is the role of, I'm sorry, I'm obstructing you, role of a mood stabilizer in such a patient? Because as you are rightly talking about, could be a bipolar.
So more than a mood stabilizer, I would still think you could also think of a low dose atypical antipsychotic, because some of the
already is on
now,
a low dose atypical like aripiprazole, 5 milligrams or 7.5 milligrams. He's already on that medication.
In which case, if he's already on the cover of an antipsychotic and there is no improvement, that's why they're seeking help, then starting an SSRI would be very much fine, because you're covering it with an atypical antipsychotic. And even for a bipolar disorder, a OFC kind of a combination where you treat with a atypical plus an SSRI is well documented, and it is quite safe. So if already he's on aripiprazole, he's not improving, then there is no need to think twice. We can straight away think of fluoxetine as an option.
Thank you. So other things, Amma, please go ahead.
Any pointers for stereotyping in ASD or OCD in ASD?
I didn't understand the question.
Dr. Vincent?
So maybe I'm just trying to think that if somebody has OCD with ASD, how do we distinguish both of them? I don't know if that's what.
I think probably how do you differentiate between the OCD and the stereotype? Maybe that is the. I think how do you point out? How do you differentiate from?
So I think we should go by the definition for each of them. OC symptoms, as you know, by definition are repetitive, intrusive, ego dystonic. The patient knows what's going on, but has poor control on that. So that's the typical definition of OC. That's what a OCD is. But in stereotypes, there is basically repetitive movements. There could be verbal stereotypes, could be language related things, but there won't be any particular cognition associated with it. There won't be this ego dystonicity. There won't be this unwanted nature of the thought. Stereotypes just happen without a rhyme or a reason. They could be motor or verbal. So that's the main way to distinguish them. But having said that, we should remember that autism kids also have OCD as one of the comorbid conditions many times. And then you will have this clear thing that, they are repetitively washing. Of course, this is not in the very small children. A little grown-up ones are able to clearly distinguish that I know that, I'm washing a lot, but I'm unable to control and things like that. Both can coexist. And when those things happen again, you could use CBT plus SSRI.
Madam asked one more question. Well-trained professionals can do a wonderful job in such cases. What about patients in small places and those who do not have the personnel or money to go regularly to higher centers? Or for those in cities who cannot afford? At least one salary easily goes into the therapies. So how do you really help them?
I fully agree, sir. In fact, India doesn't have any kind of social security or social service net that helps these kind of families. So I don't have an answer for
Just
this,
a couple of days ago, one webinar has happened. No, the therapist, the one professional from NIMHANS. It seems under national trust there is a provision for the underprivileged people to avail these, charges for the OPs, therapies, and the treatment also. But in the hundreds, not in thousands. I think every person can avail that facility. Those people who are below poverty line.
I
If
think
you
it's
go
called
to the
Niramaya or something, sir. That's the scheme,
Niramaya is the I think insurance coverage. Yeah, under that you will have the OP charges can be reimbursed, IP charges can be reimbursed, therapy charges can be reimbursed, but in small quantity, not the way now it is being usually charged in the cities. So I think there are no more questions. I think we can wind up. Back to the thank you very much, Vishal, for excellent presentation as well as answering the question and answers. And we are really benefited by your talk, especially the practical way of dealing with the children with autism. And I think now it is over to the Dr. Sharath.
Thank you.
Somebody raised their hand. I think Dr. Harini, I think she has a question.
Yeah, if she's there, she can ask the question.
No, sir. Just wanted to say, in NIPID and Rainbow, they train parents as part of empowering parents. They do parent programs or home-based programs for the parents. So they go in such rural areas and they do it themselves rather than going for the therapy centers. Just wanted to make this point. Thank you.
Thank you, Harini. That's very useful. Thank you.
Thank you, sir.
Yeah, Sharath, I think you can wind it up. Already we crossed 9 o'clock.
The team is there.
I just want to add one more point to this. All the activities that sir has mentioned are actually helpful to normal children as well. Even the parents might not accept medication if the child has autism, but all these activities, we can tell them, the child can improve their gross motor development, normal development. The child can be more brighter, smarter, and they can acquire speech more early compared to his peers and all. So they can easily do this, and even the children feel more comfortable doing all these kinds of activities at home rather than a therapy center. So playing with a ball or playing with hula hoop or with the skipping rope or doing bead activities, they might enjoy as well. So home-based activities are definitely a good option for children, normal or ASD, or with parents having all the issues regarding the diagnosis and medication as well. Thank you.
Yeah, well done. Yeah, good suggestion. See,
Dr. Mansa?
I thank you, Dr. Vishal Garu and Dr. Raman Rao Garu. I would like to request Dr. Mansaram to conclude the session for the evening with vote of thanks.
So very good evening, everyone. On behalf of Indian Psychiatric Society, AP State Branch, Child and Adolescent Psychiatry Committee, I take this opportunity to express our heartfelt gratitude to all who contributed to the success of this meaningful webinar on the occasion of World Autism Awareness Day. First and foremost, I would like to extend my gratitude to our esteemed chairperson, Dr. G.V. Raman Rao Garu, for gracefully steering the session and sharing his valuable thoughts. Now I extend our sincere thanks to Dr. Vishal sir for his brilliant and insightful talk on autism in resource-limited settings. Your practical insights and experience have truly inspired and informed us, sir. A special thanks to our IPS AP State Branch President and Secretary for their continuous support and leadership that makes such academic endeavors possible. Next, I would like to thank all the participants. Your presence truly adds value to our academic sessions. Next, I would like to thank East and West Pharma Company India Limited for sponsoring this session. Thank you all once again and wishing you all a pleasant evening ahead. Thank you.
Thank you. Thank you very much. We will wind up this session. Thank you.
Thank you, sir.
Thank you,
Thank
sir.
you. Thank you very much.
Thank you.
Bye, sir.
Bye. Good night.